Hello, and welcome to Essentials of Monitoring, putting it all together. This is Alan Schwartz, DDS-CRNA, and the idea of this course is for you to look at all these slides. They should look very familiar to you. You should be familiar with them, and they're the most important concepts from your course. Of course, I want you to know as much as you absolutely can, but this is your foundation for monitoring and taking care of a sedated patient. If you don't understand these slides and you still have questions on them, that is not a problem. I want you to talk to either your doctor that you're working with, talk to some of your coworkers, maybe they can help you with it, and then certainly we are able to help you also. Please feel free to text, email, or call Dr. Schwartz, and I'll be happy to make sure that you understand every one of these points. As in all of our lectures, we have a disclaimer, and the idea of the disclaimer is to tell you that this is the way that I practice. This is the way that I've learned over the years, and that there's other ways of doing things. There's other practitioners, textbooks, lectures, journal articles, and I refer you to those if you have any question. So our first concept is how many people should support the sedated patient during dental surgery, and that number is 3. And depending on your state rules, 3 people need to be with the sedated patient in the room and support that patient. And those personnel can be the physician anesthesia provider, 2 dental assistants, a physician anesthesiologist, a dental anesthesiologist, and a certified registered nurse anesthetist, or also called now a certified registered nurse anesthesiologist. And of course, the sedation dentist counts as one of the people that can be in the room. So what kinds of patients are you going to be working with that are going to need sedation? They're going to be fearful patients, anxious patients. They're going to need long procedures, so a lot of work can be accomplished in an appointment or a long visit. Sometimes it's even a short procedure. I've anesthetized a person before with deep sedation for an alginate impression because they were such a severe gagger. And of course, we had to go through all the processes of making sure that they were NPO, that they had followed the rules. We still do the same paperwork, the same workup on them before we go ahead and get them off to their level of sedation. They can be used for painful procedures and invasive procedures, that is sedation dentistry. So let's talk about the continuum of depth of sedation. This is going to be one of the most important concepts for you because a patient slides from one, starting on the left, all the way to the right through the different levels of sedation. There's no start or stop point. They just slide through those and they can go into that quickly. And you need to be able to rescue a patient from one step beyond where your dentist has their sedation permit. In other words, if they have a minimal sedation permit, you should be able to rescue them for a moderate sedation and get them back to the minimal level. If your dentist has a moderate sedation level, which is also called conscious sedation, you should all be able to monitor them and keep them safe and have them get down to a moderate sedation level from a deep sedation general anesthesia level. Usually deep sedation and general anesthesia are pretty much lumped together, but there's different characteristics of each, and we're going to go through that in just a little bit. So just to review, a continuum is a continuous extent. Notice that from the previous slide, the arrow went from the left to the right. It's a succession or whole, no part of which can be distinguished from neighboring parts. In other words, there's no, as we said, start or stop point, and there's no arbitrary division. It's just some characteristics that you see in the sedation level for the patient. Let's talk about minimal sedation, also called the old name anxiolysis. So with this level, there's no depressed level of consciousness whatsoever. The patient can respond to you, they can talk to you, they can turn, they can swallow, they can breathe, they can move. So there's nothing that's depressed there for them through the sedation level. They can continuously maintain their airway and breathe on their own. So they breathe spontaneously, and they can respond to any and all physical and verbal commands. So this state can be produced by pharmacological means, in other words, certain medications, and or non-pharmacological means like hypnosis, yoga, meditation levels. So they can be brought to that level depending on their training and their expertise, they being the patient. And the patient maintains normal cardiovascular function. So their heart rate and their blood pressure remain normal in their homeostatic level, I should say. As we get into the deeper levels along the continuum, we're going to lose these things because we're going to be taking them away with the meds that we're going to be giving the patient. Let's look now at modern sedation analgesia. This, again, is a minimally depressed level of consciousness. The patient can maintain their own airway and breathe spontaneously. They can respond to light touch. You can touch them on their face or their forehead or their shoulder and have verbal commands they'll be able to respond to. But they're just a little bit less alert in this level. So this state can also be produced by pharmacological and or non-pharmacological means, and the patient still maintains their normal cardiovascular function. This level of sedation is also called conscious sedation, and conscious sedation really is an old-fashioned term. And there's two ways that we can deliver moderate sedation or conscious sedation, if you will, to a patient. And those are the enteral route. Notice that I've got the words in brown because it involves the gut going all the way from the mouth all the way to the south end of the patient, if you will. And then there's the parenteral route or parenteral route of moderate sedation, in which we totally avoid the gastrointestinal tract, which is the enteral route. So the enteral route involving the GI tract is swallowing a pill. It can be absorbed from the oral mucosa in the sublingual or from the rectal side. There's drugs like chlorpromazine, which is a suppository for patients that have just intractable nausea and vomiting. So it can be given rectal along with rectal Tylenol suppositories and those sorts of things. So what are the advantages of involving the GI tract? Why do we still do this to this day? Well, first of all, it's inexpensive. You don't need any IV equipment, no sets to plug in an IV, so an administration set, IV bags, tubing, syringes, needles, medications. So it's really inexpensive to do. It's like, here, swallow this pill. Or, hey, we can put this on your skin or something on that order. It's just very easy to do. And it doesn't require sterile technique. But there are disadvantages in involving the GI tract. It's less reliable dosing because you have the stomach where this pill was swallowed. The liver is constantly guarding over whatever is in the bloodstream in the system, and it's going to metabolize it very quickly. And that is called the first pass effect. In other words, when it's first passed, the liver says this is a toxin, even though it could be a Versed molecule, it could be a halcyon or a triazolam molecule. The body looks at it. And then there's the intestines that get involved. And when someone is anxious, they're not digesting food. Their parasympathetic nervous system is not kicking in. So they're going to get an unreliable dose. So if we gave 0.5 milligram, we don't know how much is in the bloodstream. So it can have a slow onset. It's less reliable dosing. We don't know exactly what the patient's getting. Therefore, it can be unpredictable. And there's not a secure route to the patient for an emergent situation, giving such drugs as phenylephrine, epinephrine, or ephedrine. Let's look now at the parenteral route. The parenteral route also uses and is considered being the sublingual, intravenous, intramuscular, which is going to be almost as fast as the IV route getting drugs to a patient. There's intranasal, in which we atomize spray and shoot that atomized mist up into the nose. We can give such drugs as Versed, ketamine. There's Covinase, which is a local anesthetic that can be given that way. There's the subcutaneous route. That's quite important nowadays. And then there's the intraosseous route. We're going to see that in just a little bit. There's the pulmonary route, and you're already familiar with that. We give nitrous oxide that way. And in the operating room, we give potent inhaled agents, one of them being sevoflurane, to keep the patient in a state of general anesthesia. For the transdermal route, it's become very popular. A lot of drugs can be now given this way, and some really innovative things are given this. I just want to show you that in a couple of seconds. There's fentanyl, and it has doses of 12.5 micrograms per hour. It can go to 25 and 50 micrograms per hour, depending on how the patient needs to be dosed. There's the lidocaine patch, and those can be given along the back or something on this order for back pain. There's EMLA cream that can be given to the IV site. So that's a mixture of lidocaine and prilocaine. And EMLA stands for eutectic mixture of local anesthetic. So what are the advantages of bypassing the gastrointestinal tract? As you can probably guess, I'm a real fan of this way of giving medications to a patient. First of all, it's going to be very quick onset. From the time we give it, we count what's called a circulatory time, or circ time, it's nicknamed, and that's the amount of time it takes to pass through the entire system to reach every cell in the body. It's going to be a reliable dosing, because if you're giving a dose IV or IO or intramuscular, there's a really, really good chance, unless the IV or something is broken or something along the line is broken, that they're going to get that full dose of that medication. So it's going to have rapid predictability. It's going to have really quick effects, so you can start to see things happen that you want to happen for the patient. And there's a secure route to the patient. You can see on the left here, I am giving fentanyl IV, and the picture on the right is me giving propofol through a pump to a patient. So it's going to be a secure route to the patient to get those drugs to the patient, those different meds we're giving them for their sedation. And I've got a route to be able to give the emergency medications where I didn't have that with the enteral route. So drugs like phenylephrine, ephedrine, and epinephrine can be given that way. But there are disadvantages to the parenteral route of administration of medications, and they are that there's going to be a greater expense to you and then for the patient to be able to have all the equipment and supplies and all the necessary armamentaria to be able to medicate the patient. It's going to be more invasive to the patient. We have to break skin if it's in the case of an IV or an IM or a subcutaneous. So sterile technique is required so that the patient doesn't get infected. And then again, there's that possibility of infection. Let's talk now about deep sedation and analgesia. Analgesia is, again, the relief of pain. This is a more depressed level of consciousness. The patient has a partial loss of their protective reflexes, and their protective reflexes can be such things as coughing, sneezing. If you come close to their eyelashes, the blink reflex, the withdrawal reflex when they're in pain, they're going to be blunted because of the medications we're giving the patient. They may not be able to maintain their airway, because a sedated tongue becomes very relaxed and it becomes huge. It's almost like a side of beef in the mouth, and it can block the airway. They may be able to respond purposefully to repeated stimulation, but maybe not verbal commands. So if I were to take a cow horn forceps and want to extract number 30 with it, and I didn't have local anesthetic there, the patient is going to respond to that. They still respond to pain. And this level is really only produced with pharmacological means. And the patient maintains their heart rate and blood pressure, so their normal cardiovascular function. Let's talk about general anesthesia. This is a controlled state of unconsciousness. There's partial or complete loss of their protective reflexes. They have the inability to independently and continuously maintain their airway. So we have to provide for an artificial airway for them, be it an oral airway, an LMA, an endotracheal tube, a King airway, because they're just not going to be breathing real well on their own under a state of general anesthesia. The medications may even knock out their breathing. They cannot respond purposefully to physical stimulation or verbal command, but their body will still feel pain. You still have to use local anesthesia. Even though their brain is medicinally or chemically asleep with an inhaled vapor or medications we give in the IV, their brain still senses pain, very, very much so. This is again produced by pharmacological means, and they may not maintain their normal cardiovascular function. When I've got a patient that I've just put off into a state of general anesthesia and they're prepared to have their surgery, if there's no stimulation to the patient, their blood pressure and their heart rate can really drop down low. And we've got to bump their blood pressure or their heart rate till they start their stimulation. And probably the most important point I can tell you is that amnesia is guaranteed and implied in this state. So realize this is the only state where it's guaranteed. So don't promise amnesia in any of the other levels. No amnesia guarantee for minimal, moderate, or deep sedation, only with general anesthesia. So let's talk about the parts of an anesthetic. And it's interesting because it's similar to, and it can be compared to an airplane flight. An airplane takes off. The distance between two different cities or two different airports is called cruise when you're in that stage of the flight. And notice that when an airplane takes off, the pilot doesn't just fix the wheel of the airplane and point it, say, from Minneapolis to St. Louis and then walk and have coffee and talk with the flight attendants. There's constant course corrections that have to be made while you're in cruise so that you end up at the correct distant location. And then there's the landing of the plane. So in anesthesia, there is induction, just like takeoff. Maintenance is the cruise phase. So this is where we have to apply meds to keep the patient homeostatic. In other words, their blood pressure, heart rate, their breathing, where they normally live. So there's corrections we have to make along the way. And that screen that's there that you see is called an ether screen, back from way back when in history when they used to use ether so that the surgeon didn't pass out. Of course, the anesthesia provider might have passed out or gotten sick, but that is still used to this day to maintain the sterile field. I digress, but we've talked about induction, maintenance, which is cruise, and then emergence, which is the landing of the plane. Let's talk about some paperwork. There's the health history. There's a separate consent for treatment for the patient's dental work. There's the anesthesia consent, which is totally separate. We used to use a source consent, so in case we had an accidental stick with a needle, we could get consent from the patient to draw some blood from them to see if they had such things as HIV. There's the post-anesthesia instructions, and I give those to the patient while we're going through their consultation before they come in for their visit, because the patient is not going to be in learning mode when they come in that day. A lot of anxiety, they're going to be worried, their caregiver might be worried, and they're not learning. And then there's another form that we've developed that is called the Day of Surgery Assessment form. And just to let you know, all these forms are available If you go to sedationconsult.com, go to forms at the very top, and then all of our forms that I use in practice are there. So let's talk about these forms now. So with a health history, we've got to make sure that they fill in every blank and every line, and they check every box. Notice that this is broken down into the different systems of the body: the respiratory, lungs system, musculoskeletal, neurological, cardiovascular, liver, kidneys, and then others that don't fall into one of the other categories. And they can't just draw a line straight down all of them. They have to check each individual box. So if they do draw a line, say down all the nose, send them back, unfortunately, with the clipboard while you're doing this consultation, and make sure they chart the yeses and the nos. So leave nothing blank. I go through their post anesthesia patient recovery, their do's and don'ts with them. And this is a good time to do it while they're not in pain or maybe sedated or whatever. And then there's the day of surgery assessment form. This is a really important form to me. It's probably one of the most important forms that I use. It's going to give us a snapshot of what's going on with the patient's health history that day before we've started. You all are anesthesia people now, so make sure you fill in their patient name, the date, and this can be updated with another date. You can still use the same form. It should be done at least once a year. Allergies and medications are no known drug allergies. We want to know if they're allergic to any foods, especially soy or eggs, and that's because propofol is dissolved in either a soy or an egg base. But it turns out that the eggs that they're using are the yellows, so the yolks, and people are usually allergic to the whites of the eggs. And then you also want to see if there's allergy to any latex. We're not really using latex, but we're using nitrile gloves nowadays. And then you want to know if they've ever had trouble with anesthesia themselves. And some patients will say, I come up fighting, I come up nauseous, confused, it takes me a long time to wake up. And then I also like to know if any blood relatives have any problems. If we're using an inhaled agent, not nitrous, but sevoflurane or desflurane, if you're doing a general in your office, there's a thing called malignant hyperthermia, and that can really be a problem. So we want to know if any blood relatives have had trouble with anesthesia, and this is the place to catch that. Under social, we want to know how much ETOH or ethanol or alcohol that they drink. And after you ask them what they drink, you can pretty much, we were told in school, to double that amount. So if they're drinking a 6-pack or a 12-pack over the weekend of beer, you can pretty much double that. I've got to know if they're using any illicit drugs. I never report anybody. We don't do it for that reason. I want to know if they're using such drugs, especially cocaine and any of the stimulants, methamphetamine and amphetamine. And the reason is that those stimulants cause vasoconstriction, especially of their coronary arteries. So their arteries to their heart need to be wide open. There needs to be a ton of blood going to that heart tissue. So I would cancel a case. And if you've got a population where the people that you don't know or can't trust to give you an honest answer, then you can do a urine dip test to see all the different meds that are there. And then I want to know if there's tobacco use. And the main reason for that is for the person that's coughing, if they're going to cough during the procedure. I want to know if they're in pain, acute or chronic pain. I want them to tell me where it's located, and if it's on a scale from 0, which means no pain, to 10, which is, a lot of people will say, well, I'm not really, I'm in a 10 right now, my mouth hurts. And I say a 10 means you are about to pass out, or you've been going from consciousness to unconsciousness because it's so excruciating. Is that you? They'll give you a more honest answer that way on the scale of 0 to 10. LMP is the last menstrual period. I want to know if the patient's pregnant, if they're nursing. If they state that they're not pregnant, that's fine. I would circle each of those. You don't want to use benzodiazepines, and in other words, Valium, Versed, Triazolam, on a pregnant patient because the fetus can develop birth defects with that. I used to run pregnancy tests in the office, but I don't do that anymore. And if there's been a bilateral tubal ligation, a hysterectomy, which are sterilization procedures for the woman, or a vasectomy, or just abstention on their partner. So, a recent URI is upper respiratory infection, not UTI, which is a urinary tract infection. If they've had a cold within the past about week or so, are you going to want to be creating vapors from the high speed and the water vapor that's put out so that all of you get to breathe that cold virus? I think not. And for a child that has had an infection, an upper respiratory infection, the rule of thumb, the way that we practice in anesthesia, is to wait at least 14 days to be able to treat the patient. Now, if they're in pain and there's an abscess, that's a different story. I would not probably use any sedation on them because they more than likely would need to be intubated if it gets to something in that order. I want to know if there's any chance of hiatal hernia or reflux. I don't ask them if they're obese. I'll just check the box. I will check if they've had their immunizations if it's a child, if they're immunosuppressed or taking steroids. That's going to be important to know. If they're in cancer, chemo, or radiation because of their healing, and if there's any anemia or bleeding disorders. I will have them, if possible, even though I know that they're NPO, I will have them swish with some water to clean the bacteria out of their mouth. And if I'm using medication like glycopyrrolate or atropine to dry their saliva, I want them to get their contacts out. And then I have them, the patient initial. This has got to be an adult patient or the patient's guardian if it's a child. I want to know they're telling me that they haven't had anything to eat or drink for the past 6 hours, that they've not smoked, vaped, or ingested any illicit substances. If they've smoked or vaped, will go about 2 hours for them for NPO. If they've injected or if they've ingested any drugs, we've got to find out what they are. Ingestion means at least 6 hours of NPO time. We'll go through that in just a bit. Someone else needs to drive them home no matter what. Usually we don't let them take an Uber or anything on that order. And then a responsible adult is going to be with them for at least the next 24 hours. The bottom half of the form is if they've taken their meds with a sip of water, I want to know what they took and what time they took it. Then I will observe and do a physical examination on the patient, look at their thyromental distance for their airway. I look at their neck range of motion. I listen to their lung sounds with a stethoscope and their heart sounds. Then to the right, you can see I record their NPO status for that day, their nothing by mouth, and I want to know their height and their weight. Then I have them open their mouth as wide as they can and stick out their tongue. And that will tell me their Mallampati classification, the MPC. Then we have to have a diagnosis for the patient of why we're doing the anesthesia that day. So you're going to have to either write in or circle one of these diagnoses that are there, like we're doing a crown, we've got loose teeth, we've got an infection, just whatever, poor repair. You've got to have a diagnosis. I look at their neck. I look to see if if they've got good range of motion, and circle if they've got a potentially difficult airway. I write in some remarks, and then we assign the patient a physical status. And we're going to go through that in just a bit. So we've got a diagnosis above where we said crowns, bridges, poor repair. Then we have to have a treatment plan. And there's MAC, which is monitored anesthesia care, which is IV sedation, patient still with us. They're able to respond. So this could be moderate sedation or even deep sedation. I've heard it called that for either of those levels. GETA is general endotracheal anesthesia. TIVA, it's actually pronounced TIVA, is total intravenous anesthesia. And then LOC is a local standby. That's where we hook up the monitors. A dental office isn't going to do this, and we observe the patient. We don't give any medications to them because they are so severely sick. They're going to be an ASA 4 or 5 patient. They're really sick. Then I check the box. We've discussed the anesthetic with the patient and any alternatives, and that all the consents are signed. Then I will sign that. At the end of the case, we write a post anesthetic note and then who the patient is discharged to. And if they're the caregiver or there might be another caregiver, we'll go ahead and list that there. So this is NPO status. This is the NPO guidelines. These came out in 2017. These are not hard and fast laws. They're rules that we follow in anesthesia and that you and your office needs to follow as a sedation dentist. So clear liquids, in other words, a liquid you hold up to the light and you can see light through, is 2 hours. Breast milk, we're not going to worry about too much, but formula, non-human milk, and a light meal. A light meal is defined as, say, some crackers or dry bread, maybe a hard-boiled egg, nothing with fat on it, no butter or anything like that, and some clear liquids is 6 hours to allow digestion to move the substances away from their stomach, away from their throat, so that they don't throw up and then possibly aspirate into their lungs, which means pulling nasty stomach contents down into their lungs, which you could possibly die from. If they've had a heavy meal, that is at least 8 hours. And that's just a normal meal. If you were to go to a restaurant, have butter, have rolls, have barbecued ribs, whatever, it's got to be 8 hours. Something new that's on the bottom of this NPO form is, again, if they've smoked, vaped marijuana, it's 1 to 2 hours they should be NPO. Anything ingested, I fib to you, it should be 8 hours. So that's considered 8 hours, not 6 hours for someone that's ingested any substance. Let's talk about consent, consent, consent. We've got to get consent from the patient to be able to treat them, both for their dental treatment, so that's the treatment consent, the anesthesia consent, which is just going to be solely for the anesthetic, and then the source consent in case we have an accidental needle stick and we need to draw blood from the patient from a lab. There's a couple of concepts I want to go through with you, and one of them is assault. And it's the words assault and then battery are used wrong in the media. Assault is the threat of an action. So if I say, I'm going to punch you in the nose, that is, so I've touched the patient, but I said I was going to do this action to you. If I've threatened you or if I've informed you what I'm going to do, that's called assault. When I've touched you without your consent, without you saying, yeah, go for it, or signing your consents, that's called battery. And the dentist can be sued for assault and battery. That's why we have got to get consent for the patient. Let's talk now about ASA, which is the American Society of Anesthesiologists Physical Status Classification System. Every patient gets a physical status classification. And as we get bigger and larger in the numbers, it's going to be more and more difficult to treat that patient anesthetically. So, one is a normal, healthy patient. They're not taking any kind of medications, they're just normal and healthy. Two is a patient with mild systemic disease. So, this can be someone that, say, is missing part of their thyroid, or they might have low thyroid action and they're taking thyroid meds to keep them normal. Or it can be somebody with high blood pressure that's taking meds to bring them back to that homeostasis, that level where they normally live when they're healthy. 3 is a severely systemic disease. So this can be someone with severe breathing, blood pressure, heart problems. 4, their disease process is so severe that it's a constant threat to their life. 5 is a patient that is so sick that they're not expected to survive unless we get them into the surgery. 6 is a declared brain dead patient. And obviously, you're not going to be working on those in the dental office, but they have gotten a separate ASA physical status for that. So, depending on your level that your dentist has or that you have for your sedation, you're probably going to be working on ASA 1s and 2s. And make sure that you don't give somebody a 2 that is really a 3 patient, because if there's any complication, the board is going to look at that if there's any complications with the patient. So be honest with it and make sure that you're taking care of that. I have a deep sedation and general anesthesia permit, and I'm able to work on some ASA physical status 3 patients, but I won't touch a 4 or 5 in the office. There's just no way. And then there's the E class, which is emergency surgery. Again, you're not going to see that in the dental office, but if, say, somebody is a normal, healthy patient and they get into a severe car wreck, they might be healthy, but now they could have some severe problems internally. So they're given the status 1E. So let's identify the 5 critical patient vital signs. And they are blood pressure, respiration, temperature, pulse, and saturation pulsatile of oxygen. It used to be called, when I started anesthesia, SaO2, meaning arterial, and they changed that to P, which I'm glad they did, because you've got to have a pulse by the probe. There's some other vital signs that are considered critical that you should gather for the patient, and you saw on the pre-op form that we did that. One is height. You can see the father is on the left and the son is on the right. His name is Robert Wadlow, and obviously at 8'11", he's going to be treated a lot differently with his dosing and his airway and such as his father on the left. And then weight is also considered a vital sign. It just depends on the textbook. We should be dosing on body surface area, but that would mean that we'd have to send the patient to a lab to have them be dunked underwater to get their body surface area. So we use weight for that because it's pretty close to body surface area. And then don't forget to assess the patient's level of pain. I want to know where they're at on their pain level before we've even touched them, and I want to know where it is. If it's their lower back, I want to know ahead of time so that they can't say, well, I didn't have any back pain before I saw you at the office. So you said, no, that isn't true. You told me preoperatively you had back pain. Let's talk now about the physiology and the importance of the 5 critical patient vital signs. So make sure you understand these. Blood courses around our bodies in a circle. So oxygenated blood and nutrients and gases and such go to the patient and circulate to every cell. So that's through the arterial blood. And you can see that it's bright red. It's on the left there. And then there's deoxygenated blood, waste, and carbon dioxide that's put out by the cells. And they're pumped back along the circle, back to the heart, and then sent to the proper organs so that things are taken care of, like CO2 breathed out, or detoxification in the liver, or the making of urine in the kidneys, whatever. Each of the major organs, the lungs, the kidneys, the liver, and the brain, need a ton of blood supply to keep them alive. Especially the brain uses a lot of blood supply. It needs glucose, which is the fuel for the brain, brought to it constantly. But these are the major organs that command a big supply of our blood. That's why we've got to have homeostasis so that our heart is pumping blood to the patient, that there's enough pressure there to perfuse the tissues of each of these major organs. And don't forget, too, that the heart needs oxygen and it needs to have its waste products taken away. The heart receives blood during diastole. So when the heart is resting in that stage of filling up, that's when the heart's getting its fair share of the blood. So if a heart on certain patients is beating very, very fast, there's not enough time for the heart to fill up so that the blood can then reach each of the cells of the heart during diastole. So it just depends on the patient. Some people are trained and they're athletes, they're able to do that, younger patients, but some, like an older patient, are going to have trouble, and there's going to be a mismatch between there's just not enough blood pressure going through the coronary arteries to be able to pump that to the heart, especially itself. Let's talk about pulse. Pulse is the actual beating of the heart. I would know, and you need to know each of these waves and then what they mean. Each one of these waves represents something physiologically that's happening with the patient. Make sure you know this cold. Know what a P wave is. Notice it goes in alphabetical order. Then there's the QRS complex, so PQRS, and then there's the T wave. So let's look at some dysrhythmias of major concern. I want you to know what a normal rhythm is before we go on and you are able to look at and be able to recognize lethal rhythms or bad rhythms. Just know that the P wave starts in the sinus node. That's some tissue located by the right atrium. It sends its signal out to the left atrium simultaneously. That's what creates the P wave. Then the P wave goes down to the atrioventricular node, the AV node, down the bundle of His, and then it splits into a right and left bundle branch. And that's what creates the QRS complex. Notice how large the ventricle is compared to the atria, and that's why the QRS complex is so large, that big wave above there. Then there's the T wave, which is the repolarization. There's a sodium potassium pump that's pumping sodium into the extracellular fluid and potassium into the heart cell, the cardiac cell. And that's repolarization. For the ventricles, repolarization for the atria occurs during the QRS complex. So sinus rhythm is defined as a P before every QRS, and it's a rate, this is for adults, not for children, of 60 to 100 beats per minute. Sinus tachycardia, whenever you see sinus, that means there's a P before every QRS, and it's greater than 100 beats per minute. Sinus bradycardia is a P before every QRS and a rate less than 60 beats per minute. Then there's a regular rhythm. So if you will, if a heart's beating like that, is a regular rhythm. Or there's an irregular rhythm. So it's irregular. And then there can be regularly irregular rhythm. And during your lecture, you had a chance to see where there were 2 beats on the patient, and then it was followed by normal beats, normal sinus beats. So it might have been something like. So know what the P and what the QRS are doing. Remember, from the atria, know the ventricles, what wave is created there. It's going to be important for you. Then let's talk about respiration. Respiration is the process of breathing, where we're bringing oxygen in from the environment to the lungs. They go through the alveoli. You can see that a normal, healthy alveolus has got just hundreds of millions of little tiny balloons, which have a lot of surface area. And then intimately associated with those alveoli are blood vessels. So deoxygenated blood, you can see that coming down to the alveoli, where the gas is going to then diffuse across the alveoli and you're going to breathe it out. And don't forget, that's where we use end-tidal CO2. And then oxygenated blood, the oxygen is going to diffuse into the alveoli, and we're going to then pick up the oxygen, circulate that back to the left side of the heart, and we're going to then perfuse all the organs, every cell in the body. So the deoxygenated blood is coming from the lungs, which is the right side of the heart. So have a picture in your mind's eye of how blood is circulating, what the waves mean, how the lungs and the alveoli function in bringing oxygenated blood to the patient and then taking away waste products. Temperature. Any one of our chemical reactions in the body are going to involve and be best served at normal body temperature. That's why we're at 98.6 degrees Fahrenheit or 37 degrees Celsius. Blood is going to clot best at normal body temperature. If the patient's cold, their heart rate increases, which is stress for the patient. Their respiratory rate will increase, and hopefully it's increased to a point where they're able to oxygenate the tissue and get rid of the gas wastes. Drugs are going to be metabolized and eliminated very slowly because the liver is cold. Blood isn't going to clot well, so wound healing is going to be delayed, and if it's delayed, will then cause wound infection. So we've got to keep the patient warm. Look over this slide where we talk about each of these things. If the patient is cold, with their heart rate, respiratory rate, drug metabolism, wound healing, and wound infections. My favorite monitor, the first monitor on and the last monitor off, is SpO2, or the pulse ox, or the pulse oximeter as it's called. This was invented through space technology from our astronaut program from NASA. This is where this was developed. So the way this probe works is there's two lights that shine. One of them you can see, and you've looked at a pulse ox before, it's a red light. And then there's the infrared. So it's still a red color, but our eyes cannot detect it. And then the amount of light coming through, the amount of redness coming through, will be detected by the diodes. It's brought by wire up to the electronic processor, where a calculation is made using the Beer-Lambert law we saw in your lecture. And then it will spit out a pulse oximeter wave as well as an oxygen saturation wave. Realize that then, since red light is used, that we're really looking at the redness of the blood. Heme, which is in the red blood cell, can bind up to 4 oxygen molecules. So you can see if it's only binding 1 oxygen molecule, if only one amount of oxygen is there because of what the patient's breathing, that blood is not going to be as red as if there were 4 oxygen molecules, which is the maximum possible on the hemoglobin molecule. Plasma is interesting in that it carries a little bit of oxygen and CO2, and it's a big part of blood. So it's carrying hormones, nutrients, proteins, waste products for excretion, clotting factors. It's going to bring the defense cells against bacteria, viruses, and fungi. It carries water. It maintains the blood vessel shape, blood pressure, and body heat. So it is extremely important for the cells and for our bloodstream to have plasma. It has a lot of functions. Let's identify normal patient vital signs so that we'll be able to recognize when something is abnormal. For adult humans, we're not talking about any pediatric, normal blood pressure is less than 120 systolic over less than 80 diastolic. Normal heartbeat is 60 to 100 beats per minute, so that's normal pulse. Normal respirations are 10 to 20 breaths per minute. And while we're talking about breaths, I want you to make sure that you understand the concept of FRC because it's really important in anesthesia. Remember, FRC is functional residual capacity. So if a person's breathing tidal breaths, that's the VT, the FRC is extra lung capacity that's got oxygen in it if the patient should lose their airway. So it acts like scuba gear so that we've got extra oxygen there. And remember, there's certain things that can mess up FRC, like severe obesity, pregnancy can also mess that up. Normal temperature is 37 degrees Celsius, as we talked about before, or 98.6 degrees Fahrenheit. Normal saturation pulsatile of oxygen, some textbooks will say greater than 92. I sure like greater than 94. And we saw with the oxyhemoglobin dissociation curve how we drop the SAT, that the amount of oxygen that's in the bloodstream drops very rapidly. The PO2 at the bottom of this graph shows you how rapidly it drops. How we went from a SAT of 100 and a PO2 of 100 to a SAT of just 94, and we're at now a PO2 of 70. So make sure you understand that. When we got down into the 86% range, we're in danger. We've got a PO2 of 50, maybe 40%, and it is just not compatible with life when we get that low. At 40, we're in the severe hypoxia range, and the patient's just absolutely not getting enough oxygen to all the cells in their body, and they're in danger, and there could be imminent death for the patient until we get that oxygen saturation up. So 92%, some textbooks, like I said, say, I like 94%. So now that we know normal, let's talk about abnormal patient vital signs and signs that we should be concerned about with their vital signs. Anybody that's got hypertension, I don't test on numbers or anything on that order. Just know you're greater than 120 over 80. And these are the new guidelines. I don't know which year. I think these were 2017 also that these came out. So if you've got somebody to 130 systolic to 139, over 80 to 89, that's called hypertension stage 1, and organs can be damaged with this. This is really tough on the heart also, having to work and push through these blood vessels. Stage 2, they've got a blood pressure of greater than 140 over greater than 90. Now, some patients are going to come in nervous, but if they've not taken their blood pressure medications and they've got a blood pressure of, say, 199 over 102 or 140 or something on this order, we're going to be really worried about that. And I would cancel the patient that day. There's no way I would treat somebody with a blood pressure like that. Then a drop in blood pressure is hypotension. A lot of times the patient will faint or pass out. And then let's look at some abnormal EKG patterns. We saw that normal sinus rhythm was a P before every QRS. You can see that the beats are regular. And so this is for an adult. For a child, which is usually 8 or less in age, we start to call a patient an adult when there's breast development or if there's armpit hair development. So usually that's about age 8 or so, they're considered adult. But for a young child, especially the youngest child, is going to be over 100 beats per minute. And believe it or not, we call that a sinus rhythm, even though it really is a rate that is normal for that patient. and it's over 100. So we've got to look at the patient and how much oxygen their heart is consuming with a rapid heart rate. And we talked about that earlier with the amount of time for diastole, for the heart to get its fair share of blood. Because older patients are going to have atherosclerosis, they're going to have really fixed artery size. They're not going to be flexible. They may not be getting enough blood to the heart muscle. So there's a blood perfusion mismatch, it's called. Some patients, even with a slow heart rate, if they're very athletic, like we see with Chuck Norris here, his normal resting heart rate might be in the mid to high 40s because his heart muscle is so strong. So, say he's a 48 heart rate. With a child at a 48 heart rate, a newborn, as you see in this, that is considered cardiac arrest, and their patient has imminent chance of dying in that case. So, people under 8 need fast heart rates. And we don't want ultra slow heart rates also for the adult patient. They could be having hypotension, which is the drop in blood pressure, and approaching cardiac arrest. This is the dysrhythmia. Notice I call it dysrhythmia as opposed to arrhythmia. Some people will use arrhythmia, but to me, if you're using arrhythmia, that means that there's no rhythm, where dysrhythmia is a dysfunctional rhythm. So this is atrial fibrillation, nicknamed AFib. You can see that there's a bunch of crazy looking P waves there because of where the leads are placed, and that the ventricles, their QRS complexes, have no rhyme or reason. And they have their own intrinsic firing. They will fire without a P wave reaching them. So notice that it's also a chaotic QRS complex. They're not spaced well. There's no talk between the atria and the ventricles. These are premature ventricular contractions. Notice that they are kind of upside down, and this is an abnormal beat of the ventricles. The next slide is ventricular tachycardia. This is a lethal rhythm. It needs to be treated with your CABDs, early defibrillation, start circulation right away. This is a 911 call. I'd like to show you on a normal EKG while we were putting in an AICD for the patient. Toward the left of center, you'll see real VTAC. Then there's VFib, which is just a quivering of the ventricular muscle. No blood's being pumped. The patient is about to go flatline unless we intervene, and then hopefully luck will be with us. ACLS does not in a lot of cases work, but we still have to go to try and resuscitate the patient and follow our CABDs. So this is VFib, or ventricular fibrillation. Then the patient will go to an agonal rhythm, and then they'll progress to flatline, which is death. With breathing, we've got rapid breathing, tachypnea, dysfunctional breathing, slow breathing, dyspnea, bradypnea. No breathing is apnea. That's usually due to obstruction. Obstruction, the big obstructor is the tongue, and you'll see as the diaphragm contracts, and then there's no expired gas, they will be in a rocking horse type of pattern because no gas is moving. If there's crowing, wheezing, snoring, the patient is barely squeaking air by, and again, silence is total obstruction. Wheezing, if you're listening to the patient, is narrowing of the bronchioles. So we've got to be able to treat that then before we treat the patient. And you'll see in other lectures that is treated with coughing and deep breathing, or with something like albuterol or Primatene Mist. Aspiration is a really good chance of death for the patient, so it's got to be looked at as something really crucial to not happen. That's why NPO status is so important. This is where gastric contents, stomach contents are emptied into the lungs. Let's look at end-tidal CO2. So as a result of all those chemistry reactions that we saw in the body, we saw that the cells use glucose, they use oxygen, they make ATP, which is a gasoline, adenosine triphosphate, that the muscles use and such, but that in that reaction, CO2 is put out, carbon dioxide. So let's look at then end tidal CO2, which means the end of breathing CO2. It is a standard monitor now. It used to be optional, but now it's mandatory. So there's two types of systems. If you look at this gentleman wearing the mask, you notice that there's chance that he's going to entrain or bring in room air. So that's called an open system. The person breathing the nasal cannula, they're also breathing in room air. That's an open system. If someone's got an endotracheal tube or an LMA or a King airway, that is called a closed system. They're only breathing the gases that we're giving them. So the normal capnographic, which is the tracing pattern, is if there's no CO2, they're probably taking the breath at that point. As they exhale, CO2 is going to climb until they finish exhaling. Then they're going to take their breath and CO2 is going to drop down to zero again. So we look at that pattern. Notice that the end tidal CO2 pattern looks like hills and valleys. That's an open system. Where a closed system, it's going to be square or rectangular waves in what we saw above when we were describing the capnographic wave. As far as temperature goes, if we're shivering, our muscles are shivering and using oxygen that I would rather have go to all the other cells in the body, not to the muscles, to be used, that oxygen being consumed for other things. I want them to go to the organ. So we want to keep the patient normothermic, normal temperature. And that could be preventing their getting cold with a blanket. It could be an electric heating pad. With abnormal SpO2 readings, it could be because of the position of the sensor on the digit. It could be a cold digit. If there's not a lot of circulation there, we've got to have pulse by that probe, that infrared and red, those diodes that we saw in those lights. Fingernail polish can block it, and we can turn the probe sideways so it shoots through the finger that way, or put it on some kind of other thing like a toe or the nose or the earlobe or whatever. And if there's no pulse, there's not going to be an SpO2 reading. Remember that you've always got to be with a patient. Remember the number 3 for why you've got a supervised patient that are under sedation. As far as blood pressure goes, the cuff has to go at least 80% around the arm. Ideal is 80%. So when you start to wrap it and you've got the Velcro in your hands, you want it to go 80% around the arm. If it's too large and it goes way around the arm, the blood pressure reading is going to be artificially low. And if it's too small, the blood pressure reading is going to be artificially high. Make sure you know how to practice Korotkov sounds. Take and read that over. You'll see that in the slides here. Each of you should be able to perform manual blood pressure readings and know what the Korotkov sounds are. As far as pulse, besides the EKG, we can monitor pulse in the femoral region, and that's where we go when we're down in the groin area, because there's a large iliac artery there that will give us a pulse reading. Of course, you're taught in BLS the carotid pulse, and then there's the radial pulse on the thumb side of the wrist. Notice that we said that there is the EKG. I would know where each of the different 3 leads go. The white over the right, and then the smoke above fire. Respirations we can monitor with a precordial stethoscope, listen to their breathing and record it. Temperature, the only time you really have to record temperature is if you're doing a general anesthetic with an inhaled agent. But I'd just like you to see that there's ways that we can plug into the monitor with these different probes or with a liquid crystal diode over their forehead to monitor their temperature. So just keep the patient warm, not overly warm, but just normothermic. And look at the patient that they're pink, their skin is pink, lips are pink. If you pull their eyelid down slightly, their lower eyelid, that's called the conjunctiva, that's nice and pink, as opposed to these pictures of the patient with the blue lips and the clubbed fingers with the bluish fingers. So we're going to want to look at those things on the patient: the color of the blood, the nail beds, the lips, the skin, how they're breathing, how they're positioned in the chair so that they're exchanging oxygen well. We want them to be in ideally a sniffing position with their head forward, neck up in the air slightly so that they're moving air as best that they can, not slumped or something on that order, so that they're not exchanging gas well. So just don't leave the patient alone. As far as monitoring children versus adults, it's as if the human being was two different types of human beings. Children are so different from adults. So we're looking at, with the child, they've got a larger tongue, a very narrow airway compared to the adult. They've got a larger head, much faster heart rate, so there's a lot of metabolism and a lot of oxygen demand going on. We know that kids have a lot of secretions. They're pretty juicy. They've got narrow nasal passages, and there's not a lot of FRC in those pediatric lungs. And they lose temperature really fast, especially from their heads. Let's now discuss pharmacology for sedation monitoring people. Know that pharmacokinetics, know the difference between that and pharmacodynamics, is the absorption, distribution, metabolism, and excretion of a drug. So absorption of a drug could be through one of the routes that we talked about earlier. So distribution means that the bloodstream is bringing blood into the extracellular fluid around the cells through the capillaries. They can be absorbed into the intracellular fluid. There can be distribution into the fat. And a lot of our inhaled gases that go through the bloodstream will go into the fat, and then later on, they'll be discharged from that storage fat and then exhaled through the lungs. But once it's reached the intracellular fluid, it can be then also exchanged into the other areas, such as the cerebral spinal fluid, the peritoneum, which is the area of the abdomen, out into the fluids there, and then into the synovial fluid of joints. For a pregnant patient, they can be distributed to the fetus. Metabolism is going to be involved mainly by the liver. There are a few drugs that are broken down by enzymes just within the bloodstream, but the bulk of metabolism for the medications we give patients is going to be through the liver, through the processes of adding oxygen, taking away oxygen, or breaking molecules with water. So there's oxidation, reduction, or hydrolysis. And then we can also add a molecule of the drug, say fentanyl or Versed, and they can be excreted either in the urine or they can be brought through into the intestines, and then we would poop that out. And here is a system showing how through the bile ducts, which involve the gallbladder, that the excretion of those molecules can be brought to the intestines, and then eventually, like I said, we'll poop it out. Or in the case of a soluble drug, water-soluble drug, we'll pee it out through the urine, through the kidneys. Pharmacodynamics, it's got the letter D there, is what the drug does to the patient's body. So does it raise blood pressure? Does it lower blood pressure? Does it relieve pain? Does it dilate the coronary arteries? Just whatever. That's the pharmacodynamics of what it does. Let's look at some properties then of getting a patient off to sleep. We know that, and you read in your lectures, that hearing is the last sense to go. We lose vision, taste, and smell, and pain is gradually lost. But if you're talking loudly or there's loud music in a room, it's going to stimulate the patient up out of their sedation. So hearing is the last sense to go. And nitrous oxide will magnify that hearing. Let's look at assessment of patient position and skin status. Since we're sedating the patient, we have got to take care of them, especially the deeper levels of anesthesia. But anytime a patient's under our care, we're responsible for their position, their well-being, their skin status. So we've got to be careful of anything that could be probing, pushing, tugging on the patient's face. It could cause trauma to the facial nerve. We could get something in the eyes of the patient artificially, something that's bad. So we've got to protect their eyes. We might want to put glasses on the patient, some kind of safety glasses. And then we don't want to hyperextend their neck because it can cause really painful trauma to the neck if we stretch their ligaments or compress their discs to try and open their airway. We don't want to do that. So we want to slightly open them and make sure that they're in that sniffing position. If they've got any tongue jewelry in, we want it out before we even start. If they say they've had tongue or lip jewelry, I've never taken it out, I'm sorry, I won't work on those patients. They've got to take them out because your luck, they would be coming loose. They would aspirate those, and then it would mean a trip that you would pay for, as well as probably a lawsuit for somebody that aspirated something in their nose, their mouth, their tongue, their lips. So when you're positioning a patient, like we see with this fellow in this lounge chair with his feet up, he's in a great position as far as a sniffing position. It looks comfortable to me. He looks comfortable. And this is what you want to see with your patient. You want to see them be comfortable. So when you've got the patient there in the chair, maybe some blanket underneath the knees, something to take pressure off their back, maybe a pillow under the back of their neck by their occiput to get them into that sniffing position. And we don't want them to cross their legs. Patients, as they fall off to sleep, will do that, which is going to decrease the circulation to the legs. So the legs should be apart and they should have something underneath their knees to take pressure off and provide circulation down below. But if they do cross their legs, they can develop venous thromboembolism. Anytime we have blood that is not circulating well, that is stagnant, we can develop a clot there. And some of these clots can lead to severe injury or even death. So venous thromboembolism is also known as VTE, venous thrombosis, DVT or deep vein thrombosis, or a blood clot in the legs. Know these definitions. A thrombus is an abnormal clot in a vein. An embolus is a clot that is moving. It's in a vein, it's broken away, and it's moving along in the circulation. Remember that a vein carries deoxygenated blood to the heart. It's the low pressure side of the system. So when we walk, we're squeezing veins. And we've got valves inside our veins to make sure that the blood is constantly flowing in a circulation to the heart. But being a patient in a chair, especially certain patients, they could develop stagnant blood because their veins are not being squeezed or moving every time we move our legs. So stagnated blood can form clots. It's either a clot, which is also called an thrombus, or a moving clot is an embolus. So the embolus will eventually reach the lungs, going through smaller and smaller blood vessels until it lodges and the patient develops a pulmonary artery PE embolus or pulmonary embolus, which is life-threatening. And we saw that this can be one of the major causes of death in the patient. So who's susceptible to a pulmonary embolus, a PE? Patients over 60, It can be even younger patients, but just generally, somebody with a weak heart, congestive heart failure, previous heart attack, history of stroke, patient with acute respiratory disease, they just don't have good circulation in their lungs, an obese patient, and a patient with a hip or knee replacement. So symptoms of a PE are chest pain, shortness of breath, a rapid heart rate, and coughing up blood. There's ways to prevent a PE, and that would be with leg massage. I would raise the leg over the heart. Of course, the high speed's not running, and then just gently move that stagnated blood. Hopefully, it's not stagnated, but move it like the person's walking. Just walk your arm from their ankle up to the top of their leg with the leg over the height of the heart. Let's talk about post-anesthesia patient recovery. During recovery, we're going to crank the oxygen up and we're going to have suction available. Some dental boards require you to have suction catheters, so you would have that in your drug kit, your sedation kit, your cart, or whatever you have, and then a Yankauer suction, which is called a tonsil suction. And then you're going to want to record recovery on your chart. So we'll start recovery there, check boxes, maintain your times up on top of when anesthesia and the procedure started and when the procedure and the anesthesia stop. And then we have to tell on paper how recovered the patient is from their sedation. So we use something called the modified Aldrete score, and we go through and look at the patient's activity, respiration, circulation, consciousness, color, and discharge criteria has to be at least 8 to 10 before we can then safely send them out of the office. And then don't forget to write your post-op note. And then I send them home with another do's and don'ts, so post-op patient list of what they should do and not do for recovery after they've had their anesthesia and their procedure. Orthostatic hypotension is the drop in blood pressure. Normally it's controlled in the body when we get up by our carotid bodies and our aortic baroreceptors in the arch of the aorta. So baro is pressure, and these receptors look at pressure and they will give a brief, very brief jolt to the heart to increase then the heart rate and then the blood pressure for just a few seconds. It's not a long-lasting thing. To be able to get blood to the brain and especially to all the vital organs. So if you sedate a patient, you're sedating those aortic and those carotid baroreceptors, and you don't want to sit a patient up fast or they could crash on their blood pressure. They'll become orthostatic hypotensive, drop in blood pressure. So it's a brief jolt to increase their blood pressure for just a beat or two to keep blood flowing to the major organs, especially the brain. So your older patient and your sedated patient are going to have blunted baroreceptors and will potentially have orthostatic hypotension, which can lead to them passing out or developing nausea and vomiting and possibly aspiration. So set the chair up slowly and in increments. And you have to be available for the patient in your office for the next 24 hours. So let's talk about the basics of what to do with abnormal vital signs. You have been given with your notes, and I would print them out and look them over and make sure you have those in your emergency drug card in your office. The algorithms that I use to treat a patient in one of the 13 emergencies that are common to dental practice and medical emergencies in the dental office. And I've also given you a quick and dirty cheat sheet for your dentist on how to dose the emergency medications. So before the case starts, everybody's ready to rock. Everything in the office is ready to rock. The patient is tuned up and ready to rock. So the patient's ready, the operatory's ready, monitors are ready, oxygen is available, and ready to go, and it's got a full tank or at least a half or three-quarters of a tank, whichever, of oxygen, and you know where the next tank, spare tank is. Suction's available. Meds are available, especially emergency medications. You've got your anesthesia cart or emergency cart nearby, and you're able to communicate with each other. And it's good to use a checklist to make sure you've got everything in place so that you're ready then to treat the patient in your office. I know it seems like common sense, but part of the operatory is ready thing is that we use one needle, one syringe, only one time on the patient. So once you've put the plunger into the barrel of the syringe, you've brought contamination in there. And if the needle has then touched even the outside surface of the patient's IV, it is contaminated. Do not use any of that on another patient. So here we see the picture bringing the syringe into the barrel of the syringe. And just know that you just don't reuse things. So read over these myths and truths regarding the one medication, one use, one needle, one time, one syringe, only one time use for the patient. Know the difference between a single dose and a multiple dose vial and when those expire. For single dose, it's going to be, if it's unopened, the date that is on the label of the medication. If the top is popped on a single dose vial, remember that there's no preservative there and it expires that day. So if it's unopened, again, and it's a single dose vial, it expires on the last day of that particular month. So if it's MAR 2034, that's going to be March 31st of 2034. And remember that the single dose is expired the day that you pop the top on it, as opposed to the multiple dose vial that's got preservative with it. All these drugs need to be drawn up in a clean area. If there's a patient in the treatment area, you should not draw another patient's drugs up there. And remember, like we say, if it's a multiple dose, it's got preservative. So an unopened multi-dose vial will expire on the last day of the month. And if it is an opened vial, you have to then put a mark somehow on it on the day you opened it, and you count 28 days forward, and that's when a multi-dose expires. And just make sure there's no contamination within the vial. And the practitioner should draw up their own meds, especially if they're scheduled medications. They need to be kept with the practitioner and drawn up by them so that they can see what they've drawn up and that there's no diversion that's done by any of the staff or any of the people working around these medications. And make sure while you've got the syringe in your hand that you properly label it, put the concentration, the date you drew it up, the time you drew it up. And I put it sideways, that label, so that you can then see the numbers for the patient. Another thing that we do is to, if it's a multi-dose vial, is to wipe the top with an alcohol wipe and then scrub the hub before you inject it into the patient with an alcohol wipe. So let's look at the 13 most common dental office medical emergencies, and they are the general emergency response, hypotension, hypertension, laryngospasm, acute airway obstruction, cardiopulmonary arrest, allergic reaction to drugs, angina pectoris, in other words, chest pain, possible MI, possible myocardial infarction, emesis, aspiration of vomitus, convulsions and seizures, oversedation, hypoglycemia, asthma bronchospasm, and then respiratory depression. So, with the general anesthesia emergency response, you quietly alert just the people involved with it. The office does not have to usually go into chaos. So, this is in general. Just the people that working with the patient, the people that need to know are involved with it. Make sure that you position the patient safely. And every one of the emergencies, important to know, are based on the CABDs: circulation, airway, breathing, early defibrillation. Every one of them, that's the backbone for any anesthesia medical emergency that you learned in your BLS class. That's why you have to have BLS, basic life support. Oxygen is one of the first emergency drugs we give the patient, so have that there. And a bag valve mask, which should be maybe attached to that anesthesia cart. Notice that I said call 911, but we should be able to in-house treat 911 patients. So if you see all the above question and one of those is 911, look at that with a skeptical eye, because it may not be all the above, because we should be able to handle a patient that has passed out. In other words, hypotension. If somebody's had a mild allergic response, we should be able to handle that and not necessarily call 911. And then be ready to listen to and carry out orders. So these apply for every one of the emergencies. So let's talk about hypotension. For your test, will go through and do things to the patient. I'm going to go through steps, and I want you to tell me then, out of a list, what emergency is for the patient. So for hypotension, we're going to want to get the patient into a head down, Trendelenburg position, elevate their legs. You may have to lift them up in the air to get blood toward their brain and their central circulation. Crank up the oxygen, crank off the nitrous, open up their IV fluid to get their pressure up with fluid intravenous, and have another bag ready so it doesn't run out. In some states, you need to have an ammonia capsule there. I really don't use that for a hypotensive patient, but check your state's rules to make sure to see if you need an ammonia capsule. We're going to either use ephedrine or phenylephrine depending on the blood pressure's drop, and then if there's a needing to be a boost in heart rate or not. And then cold washcloths then for the patient. So here we are elevating the legs over the head. And there's the drugs that we would give to a patient: ephedrine, inhaled ammonia, or phenylephrine. Some of those drugs are single diluted. One of the drugs is double diluted. It comes too potent. Let's now look at hypertension. Hypertension is a different animal in that we have to do diagnosis for the patient. Some of the causes of hypertension, and they're all treated differently, are due to pain, anxiety, a stroke, heart failure, a myocardial infarction or an MI, or it could be a hypertensive patient that didn't take their meds, or they took them at the wrong time. They just didn't even take them at all. Recall the autonomic nervous system, the parasympathetic and the sympathetic side, that balance each other. Know that the neurotransmitters on the parasympathetic side are acetylcholine, and then on the sympathetic side is norepinephrine, and that they have two different anatomies, but that they innervate the same organs and they counterbalance each other. One's going to slow down the system, the autonomic system. One's going to speed up. In the case of the sympathetic, it's going to speed it up greatly. What's going on with their innervation of each of the organs. So for example, with the heart's going to rapidly increase on the sympathetic side, or if there's parasympathetic stimulation, it's going to slow the heart rate way down. With hypertension, the arterial is the primary determinant before it goes in and splits into capillaries. That muscle is the primary determinant of blood pressure. Think of a noose around the arterial. So if we squeeze the noose, we're going to increase blood pressure. If we loosen the noose, and we've got a medication to do that, a bunch of different medications, we're going to drop blood pressure. know what each of the adrenergic receptors are, what alpha 1, beta 1, and beta 2 do. Alpha 1 is going to, when stimulated, squeeze the arteriole in the artery. Beta 1 is going to increase heart rate. Beta 2 is going to cause dilation of the bronchi, which is really good for the lungs. We want those bronchi wide open. So for these patients, as we said, we treat them differently. We have different meds that you learn to use for each of the emergencies in hypertension. Would we consider calling 911? It depends on the hypertensive cause. Do we need to freshen local anesthetic? Do we need to give some more narcotic or non-narcotic analgesic to the patient because they're experiencing pain? Do we need to give a beta blocker that's increased heart rate? Or do we need to give an antihypertensive like hydralazine to loosen the noose? So there's a lot of different causes of hypertension, and there's different ways to treat it once a diagnosis has been made for the patient. There's always a difference. Let's talk about laryngospasm. With laryngospasm, we've got a new way to treat that now, and I want you to see this. We want to get the patient flat in the chair. We want to get the oxygen, but before that, we're going to want to apply Larson's maneuver. Here we are applying Larson's maneuver to a patient. This is going to be a patient that is laryngospasming, and it's going to need rapid then treatment for this. This is a newer method that's come out. We did not learn this in anesthesia school, but I've been told works very well. So think of this as your first line of treating laryngospasm. You, of course, are going to want to suction the patient, but you're going to put your fingers behind the angle of the mandible. That's where the mandible from going horizontal now starts to go vertical, and you push in hard. And it's really uncomfortable for the patient, but that's Larson's maneuver. You'll have a chance then to see with this movie what applying Larson's maneuver is. And if you look at this gentleman that's got his eyes taped, you notice that he's already had Larson's maneuver applied because the skin is red there. So you can see where that is, and you're just going to take your fingers and push in really hard on the patient to break that spasm. If you're going to use oxygen with a bag valve mask, you're going to want to apply it to the face, bringing the face, the mouth, the nose into the mask, and don't forget about the C and the E position. Make sure you have suction there. They've talked about, and some dental boards have you carry succinylcholine. Succinylcholine requires a lot of skill and knowledge to use. There should be other ways that you can break laryngospasm other than using succinylcholine. It comes 20 milligrams per milliliter, and you use only 5 milligrams, so a quarter of a milliliter, but still you need to have a nerve stimulator to be able to monitor it. Something that works better is to use intravenous lidocaine and draw up 5 milliliters of 2%. 2% is 20 milligrams per milliliter. So if you draw up 5 milliliters, you're giving and bolusing real quickly 100 milligrams, and that should then break the spasm also in lieu of succinylcholine. Something new that's come up because of a reversal agent is to use the non-depolarizing muscle relaxant called rocuronium or Zemuron. Again, this requires special teaching and a way for you to be able to do that. Let's look at acute airway obstruction. Make sure that you guard the patient's airway extremely well so that this is a never happening event. You want to get the patient flat in the chair, get them up to your height so you can see them, get the oxygen and crank it up to 8 liters, whatever they've got on. If you need to, use the bag valve mask. Try and get the Yankauer there. If it's deep within the airway, you're going to need to use your laryngoscope and either put in an endotracheal tube or use your McGill forceps to pluck the foreign object out of their mouth and unobstruct the airway. In the worst case, you would do an emergency cricothyrotomy with the kit that you have in your emergency cart. Have your IV fluids full, always have a bag there that's dripping, and have another bag ready to go. So you'll see the patient if it's just the tongue with the rocking horse movements that we talked about earlier. But if their patient's deeply sedated or they've got blockage there, we can do a chin lift or a jaw thrust, but we might need to use an advanced airway, and you probably should have those in your emergency cart. And then again, the worst case scenario is an emergency cricothyrotomy, also called an emergency cricothyroidotomy, and a 911 call. Fortunately, there's not any major blood vessels or thyroid tissue in the way. And that's what that kit looks like. It's like a 12 gauge needle that you would puncture through and then hook your bag valve mask up to it. We're getting away from the manual, if you will, analog laryngoscopes and getting into video laryngoscopes now. These are what your McGill forceps look like. The one on the right is a newer design, and the one on the left is an adult and a pediatric McGill forceps, but they should be in your emergency kit. You should know how to use them. Cardiopulmonary arrest is going to be the same as what you learn in BLS and ACLS. That's why we review it every 2 years for each of those. So you're going to want to start doing the CABDs, start pumping on the chest after you've checked for a pulse for 10 seconds or less. Know how fast you're supposed to go, how deep you're supposed to go. Get the crash cart and the oxygen and get the AED on the patient ASAP. You've got to get that on there fast and let it do its analysis. Don't touch the patient during that. Call 911. And then the drug that's used is epinephrine. There should be a number of epinephrines in your emergency drug kit. Somebody grab a piece of paper and chart times. It doesn't have to be beautiful, but just get some things written down so you can chart it later. And then it's a good idea to use your ACLS protocol cards to remind you of what you have to do for the patient after they've had their arrest. So here's some pictures of BLS going on. We've got chest compressions, we've got breathing with the bag valve mask, and we've got the AED in place ready to fire just as quickly as possible, because the patient's going to really deteriorate if they are not using their own heart for circulation. So we've got to get on it. The song you should have in your head is Living on a Prayer while you're doing your CPR. If you don't know that song, go to YouTube and look it up by Bon Jovi. And then epinephrine is our drug that we use now for cardiac arrest. And there's the protocol cards. And just grab a piece of paper. Like I said, it doesn't have to be a beautiful chart. You need to get an IV started if there's not one there. Let's talk about allergic reaction to anesthesia medications. So allergic reaction to anesthesia medications, if the patient is breathing oxygen, I would take off their nitrous, crank up their oxygen. This might be a call 911 emergency. It's certainly not going to hurt if you've called 911. Open the IV fluids because the patient's blood pressure is going to have plunged, and have several bags ready to go to keep putting it in line. The first medication that you would use, the most important, is epinephrine, if their blood pressure is down real far. Then we're going to give an antihistamine, and there's two types. There's one for the peripheral circulating, the mast cells and the basophils, where we would give diphenhydramine or Benadryl IV. Famotidine treats the histamine that's released from the gastrointestinal tract. So we've got those in our emergency drug kit. And then we'd give hydrocortisone or methylprednisolone, called Cyamedrol, to stabilize the leaking blood vessels, the membranes, that the fluids have leaked out because of the allergic response, the severe allergic response. If you see an allergic response, there's a lot of things that can happen. It will be instant rash, rapidly developing edema or lip swelling. And if that swells, the tongue's going to swell, and we're going to be into severe airway problems. The bronchi constrict instead of being wide open, and they get gunk inside of them. They've got secretions and fluids there. The upper airway, as we said, can obstruct, and if it's a true anaphylactic reaction, the patient is going to die, unfortunately, before they hit the floor. So they're going to really drop their blood pressure, and then their skin is really going to itch when they've got their rash that's forming. Physiologically, what's happening is we have an antibody from the B lymphocytes that is responding to something that it has seen before. So the patient has seen this allergen, the thing that's causing the allergy, and we have to quickly get on the treatment for that because there's just this outpouring of histamine and plunge of drug pressure and rapid airway problems. You're going to want to rapidly open the IV fluids, have other bags ready to hang because the person's blood pressure is really going to drop from this histamine release from this allergic response. You're going to want to draw up epinephrine, and you're not going to dilute it or everything. You're going to just give it intravenously. Hopefully you've got a bunch of ampules in your cart. Then we're going to draw up the diphenhydramine, also called Benadryl. And don't forget that that's used in nighttime cold medicine. So you're going to not only prevent the histamine release, but you're going to sedate the patient with that Benadryl. It's going to make them very sleepy. Breathing should continue, but just be prepared if they're not breathing when you give the Benadryl. And then give the famotidine. That will not cause the sleepiness or the sedation the way the Benadryl did. Then you're going to want to draw up hydrocortisone, and we showed you how to do that in your lectures, and give that to the patient. And have albuterol or Primatene mist ready to go. Let's talk about angina pectoris. People do call it angina also, possible myocardial infarction or MI. This is the patient's heart that's starved for oxygen. So we're going to want to crank off the nitrous, turn up the oxygen, crank it all the way up, make sure that the heart is getting as much oxygen as we can deliver through the arteries to the patient's heart muscle. Call 911. We're going to want to give something that's going to treat the severe pain that they're having from the MI or the angina pain that we talked about earlier in this lecture. So you can use morphine, which if you've got in the office dilates the coronary arteries, or you could give the fentanyl. I would give that. I would not give a non-steroidal anti-inflammatory here like Toradol or any of that. I would not do that. Have the patient chew on a baby aspirin. They could take a by mouth aspirin also. If it's severe pain, they've got sublingual nitroglycerin that's either a dissolving pill format or a spray for under the tongue. Recline the patient. Don't stress them out. You can put a cold washcloth over their head. Just maintain their heart rate and their blood pressure and their oxygenation until 911 gets there. Remember that if you call 911, you're probably going to have to submit a written report to your state dental board. And that's what those meds look like. Make sure they don't outdate, that you're constantly renewing them, and that all your drugs are up to date. Let's talk about emesis and aspiration possibly of vomitus. So we're going to want to elevate the patient's head and rapidly turn their head to the left because of the shape of the mainstem bronchi, the mainstem and then the left and right mainstem bronchi. If you're working with an oral surgeon, the oral surgeons tell the people that work with them that you would turn their head to the right. But the rest of us in anesthesia rapidly get the head up, turn the patient's head to the left. Get the emesis basin, get out your suctions, your low and your high speeds, have them ready to go and working to be able to suction and keep that stuff from going down in and the patient potentially aspirating that. So here we are turning the patient's head to the left or to the right if you're working with an oral surgeon. Things that can precipitate nausea and vomiting are food in the patient's stomach. Patients don't tell us the truth, but if there's food there, they've gone through and they've made a quick stop at the McDonald's takeout, or if they're dehydrated because they followed the NPO guidelines, they could be anxious and stressed. Certain oral or intravenous meds can cause nausea and vomiting, and those are the opioids especially. The smell of the dental office, just from some of the chemicals we use there, zinc oxide, eugenol, or the cleaning agents we use, can just really smell up the air in the dental office. And if the patient's dizzy or lightheaded, they can have that also. So just make sure that you've got the patient's NPO status charted. Have your suction ready and suction all the way down their throat, all the way down past the base of the tongue, and get all that stuff out of there, especially if it's a sedated patient. If they're able to cough and get all that junk out, hopefully they're not going to cough all over you. That's the best way for them to clear it out if they're not overly sedated. So if the patient starts to experience nausea, I would open the fluids, have another bag ready. Decadron is excellent. You've got that in your drug kit. That can also be used for an allergic response, but the other two drugs are used more commonly. Decadron is a great antiemetic, as well as ondansetron. Dentists don't normally use metoclopramide, but what it does is it stimulates the GI tract to move things out of the stomach. It causes gurgling in their GI tract to move things down into the colon. In a rescue attempt, there's inhaled vapors of isopropyl alcohol. So you can rip open a couple of the isopropyl alcohol packets that you got, say, when you start an IV, have them take some deep breaths. And you know that if you've got somebody that tells you in the pre-op assessment that they throw up a lot with anesthetic, that you could then prescribe a scopolamine patch. It's 1.5 milligrams, and it's a little circle that looks like it's on a round Band-Aid, and it goes behind their ear, just on the soft part, like where we applied Larson's maneuver. Let's talk about convulsions and seizures. When this happens, if the person's got nitrous on, we're going to want to turn it off, turn the oxygen up. But if they're convulsing, it's totally all right. And I would take the whole oxygen mask or whatever they've got on their face off so that they don't scratch their eyes, so that they don't get tangled up and hurt in any of the hoses or anything. If you can get the patient on the floor or get them flat in the chair so that they don't hurt themselves. Make sure there aren't things like air water syringes or high speeds or hoses or whatever there that they could, if they move, could jar loose and then hurt them. So we've got to protect them. This is a call 911 emergency. You're going to use some of your sedation medications for those of you that are doing IV moderate sedation. Versed is probably the one you're going to have in your office, and you're going to want to just titrate in enough so that the seizures stop. If you've got Valium, Valium is excellent because of its long half-life. And then you're going to want to go ahead and open the fluids. Make sure the patient maintains their blood pressure. Try and see if you can monitor vital signs. Keep them oxygenated and just follow your CABDs. So here we are seeing the patient in the tonic phase where there's just a lot of muscle tone and there's a lot of tenseness. And then there's a relaxation phase where they contract down and they're in the clonic phase. Something that you need to remember too is that the benzodiazepines are used for sedation as well as other uses, but we use them in sedation dentistry for that fact, for sedation. And you've got to consider half-life because something like midazolam that's got a short half-life, it might be 2 to 6 hours, might be chewed up or needing to be redosed, is what I'm trying to say. Same thing with a patient that's on triazolam. You can see these cone diagrams showing you how absolutely short some of those half-lives are. Let's talk about oversedation. Oversedation should almost be a non-emergency, a non-event in your office. And the reason is that we titrate our medications. We're going to give them slowly, let them take effect, and then if we need to dose, we'll dose a little bit more. But if the patient becomes oversedated, you've got to get them back into the level of sedation, be it minimal, moderate, deep, or general. You want to get them back to, usually it's from moderate and minimal sedation down to your permit level. So support the airway, follow your CABDs, making sure that there's movement of air. Keep checking and recording heart rate, blood pressure, and pulse oximetry. And then just wake the patient up. This would be where the hearing comes in. So we're going to vocalize. We're going to want to kind of gently shake them and tell them to wake up with a loud voice from us and get the patient back into that level where they should be. And people really respond well to the use of their first name. We have reversal agents for the narcotics and for the benzodiazepines, but they really are rarely used. You should have them there, but you should not be needing to use them because you've carefully titrated your doses. Let's talk about hypoglycemia. So this is going to be low blood glucose, low sugar. Symptoms are, and it's going to be really similar to the vasovagal response, are going to be sweating, which is called diaphoresis, jitteriness, nervousness, tachycardia, tremor, altered mental status. They may be talking or vocalizing funny, if at all, and then emesis can also occur. So the way that we treat it is rapidly by giving them a sugary soda pop, a tube of glucose, which could also be cake frosting. Check their glucose with your glucose monitor, and then follow the emesis protocol. We also have in your IV kit a vial of D50 that you can add to their IV solution. Not everybody has that though, but you should have D50 there. So there we are with the cake icing and the soda pop, glucose monitor. Let's talk about asthma, bronchospasm. The old adage that an ounce of prevention is worth a pound of cure is especially true with the asthmatic patient. So when you are reviewing their health history, that day that you're working with them with the pre-op assessment, ask if the patient's breathing well, plus you're going to have listened to their lungs. If they tell you that they're not breathing well, have them bring their inhaler. Hopefully they've got it with them to their appointment, and have them do some puffs before you start doing their sedation and start your IV and things like that. Consider postponing the case if the patient's not breathing well. You just don't want to experience having to use their inhaler during a case. So make sure they use it properly. You've got that in your instructions in your lecture materials. So some causes of asthma and bronchospasm are pollens in the air, exercise-induced asthma, breathing cold air, dust, animal dander, mold, and certain chemical odors, dental materials. There's perfumes, lotions, and creams that can cause it. So the way that we'll treat asthma bronchospasm, if it should happen during a case, is, and again, remember these steps because that will be on your exam, but remember that you can look at your dental algorithms, your emergency algorithms. So you're going to want to immediately discontinue the procedure, get the patient upright, get them calm as you can, get the dental materials away from their mouth, and then have them, if they can do it, administer puffs properly with their inhaler. Get the oxygen tank if you have to, breathe in their puffs with a bag mask valve and administer it properly. There's also Primatene Mist that hopefully you'll have in your cart for bronchial asthma. And that's what those two inhalers look like. Know how to use them properly so you can teach the patient, so that you know yourself, so that you know that they're getting the dose of the bronchodilator. We've got to get those muscles that spasm relaxed so that the airways open up. They get really, really small as we get down toward the terminal portion of the alveoli. They're tiny little narrow airways. Our last emergency is going to be respiratory depression, and it has different causes. As with hypertension, you have to make the diagnosis so that you know how to treat the cause. So just like hypertension, respiratory depression, again, has a lot of different causes. And they can be due to the over-narcotized patient, this patient that's had too much narcotic or sedation medication. So there could be over-sedation, partial airway obstruction that can be from their tongue a lot of times, or loose tissue in their mouth. The facial muscles relax and they can cause obstruction. Poor patient positioning of their head, neck, their body, their shoulders. Remember, they need to be in that sniff position. It could be from bronchiolar constriction, in which case we're going to need the Primatene Mist there to give them their inhaler. An upper respiratory infection will cause respiratory depression and bad movement of air, especially if they're taking something like Benadryl or something on this order for their cold. It can really depress their respirations. Chronic cough, the COPD or chronic obstructive pulmonary disease, the emphysema patient, the smoker, opioid abuser, alcohol abuser can have respiratory depression. And here are the treatments for respiratory depression. For the over-narcotized, we're going to want to titrate their meds, but if you have to, you're going to use your reversal. You're going to want to, with the over-sedation patient, as we said, wake the patient up, titrate your meds so that you don't get into that. If it's partial airway obstruction, get rid of the substance that's causing the obstruction, the foreign body. If the patient's not in a proper position, get them positioned, help them get positioned in the chair so that they're exchanging air. If there's bronchiolar constriction, we're going to want to go ahead and administer an inhaler. With upper respiratory infection, consider canceling the case as we talked about earlier. Chronic cough patient, I would have them, if they're not taking any medication for it, I would have them cough or deep breathe before you start the procedure. That is a gut-wrenching cough to open up the airways, and then you'll have to allow for if they should go into a coughing fit. For the COPDer, you're going to want to have them see their physician and have them optimize their breathing before they consider doing sedation on them and before you start their dental treatment. Smokers, they have to go at least 8 weeks or longer for their lungs to totally clear off. Just know that there's a chance for them to start coughing if there's a smoker. Opioids and substance abusers are just not at all candidates for sedation in your office. Same with the alcohol abuser. They have got to be clean preoperatively before you can treat them. Thank you very much. Get in touch with your test proctor, who will be Sherry, and that's her phone number, area code 573-303-7635. And you can email her directly at assesslive@hotmail.com to set up your test appointment, your live Zoom exam. Good luck on everything. Thank you very much for taking our course.